Great, so welcome everybody. Thank you so much for coming. It's lovely to see some familiar faces and meet some new people. I'm Liz Connor. I'm one of the new recruits to Southern Eye Specialists in the Christchurch Eye Hospital, but most of you who have met me before, I've been a registrar at Christchurch Hospital for a long time. I think my first research project there was in 2009, so I've been around. So I've just come back from fellowship in the United States with Dr. Ken Nischel, who's known for his anterior segment dysgenesis and management of corneal disease in children. So that was kind of merging my two loves of cornea and pediatrics. Before I left, I did a fellowship with John Rostron and Mark Elder in corneal surgery, and then sort of, was honing my skills in pediatric ophthalmology really while I was in the States. I think I saw about maybe 20 adult strabismus patients all year. So my first week back when I was seeing cataracts and age-related macular degeneration, I was like, oh man, what is this? But yeah, one of the things I learned from Ken while I was there is just the importance of looking at the whole child. And so sometimes children have syndromes that are not diagnosed and they don't have proper ocular anatomy. They don't have lids that close properly, or they have ectropion or entropion. But if you don't look at the outside of the eye and you just zoom straight into the cornea, then you're going to miss some really good clues about, how to manage the condition. And also, if you just treat the cornea, as soon as you stop whatever treatment you're doing for the cornea, if you haven't treated the lids and the lashes, you're going to go back to square one again. So tonight, this is pediatrics heavy, but it probably applies to older people as well, going up particularly into the middle-aged, working age populations as well. I'm not going to try and cover all the ocular plastic side of things, but this is more about what's important to me as a corneal surgeon, and hopefully will give you guys some good starting points, things that you can do to help manage the patients while they're waiting to be seen by us, things that you can start in the meantime so that when they turn up, it's like, oh, you've already tried X, Y, and Z, let's go to the next level. Please feel free to stick up a hand and ask any questions at any time. Why do I care about eyelids and eyelashes, and what are the role of the lids in corneal disease? How can you institute management that's going to help move the patient forward? By the time we're seeing them, we can carry on. So what do eyelids actually do? And so, it's easy as a corneal surgeon to ignore them, but eyelids are really important. When you blink, of course, you're mechanically cleaning the surface. It's like the wiper blade on the car, pushing debris to the sides. But also these two lids come in together, and as they pull apart, they're going to pull the meibomian, the meibum oil across the surface, and spread the tear film nicely to give you a good optical interface, to give you clear vision. And what does a blink do? So I really like this term, that if you think of blinking as preserving tear film homeostasis. So when you blink, the orbicularis muscle actually squeezes on the meibomian glands and squeezes a little bit of meibum out from the oil glands to the lid margin. Also when you blink, it's really interesting actually, the upper lid, as it comes down, it gets squeezed and it gets a little bit fatter. So it's got a fatter, wider edge on it. And the lower lid is drawn nasally and actually becomes thinner. And so as the upper lid comes down, it almost overrides the lower lid, and the lower lid kind of tucks in underneath it. And there's a little bit of a capillary gap there, which is actually what helps pull the oil over the tear film and spread it out smoothly. So it's actually quite a complex interaction at that point. And then the upper and lower puncta make contact and drain the tears into the lacrimal sac. So that's a whole talk for another day if you can't drain tears properly. But basically, cleanse, lubricates, protects the cornea. And what do eyelashes do? So eyelashes are really important. They actually physically catch dust and debris that might be sitting around the eyelid surface. We've all seen patients with blepharitis. If you've seen Demodex, then you'll see how much cuffing goes on around the base of the eyelashes. So they're another way that your eye is protecting from getting so much debris into the ocular surface. The other thing I've read that was really interesting is that the aerodynamics of the blink, you create a little bit of turbulent airflow, and the eyelashes actually direct that turbulent airflow away from the eye. So there's some thoughts that that's involved in the pathogenesis of dry eye as well. If your eyelashes aren't in a nice line, and you don't have thick, full eyelashes, that the air turbulence is different. So, there's lots of theories for dry eye, but that's one of them. So again, first, always starting with the history from the patient. They can give you a lot of information which will help you work out what was actually the sort of the origins of the problem of the eye. So is it, when they say it's uncomfortable, really, get into with them, is it pain or is it itchy? Do you think it's dry? Is when you say it's uncomfortable, is that because your vision's a little bit blurred and the quality of your vision's not what you want? Or is it actually like that they're actually sore and painful but you can see okay? Or are they just tired and achy? Is this worse at the beginning or end of the day? So then other symptoms, is the eye watering? Is there a mucus discharge? Any green gunk, obviously. Do they have dermatitis around the eyes from the atopy? Is there any lid swelling? And then related symptoms, so this is getting into allergies, but do they have any rhinitis, any cough, any headaches? Do those seasonal allergic symptoms happen regularly or intermittently? And then again with medical history, asthma, eczema, medication use, or new sunscreen. So I saw a little 4-year-old girl in Pittsburgh who I thought she was going to have BKC. She had horrendous looking swollen conjunctiva, almost looked like she had limbitis, really puffy red skin around her eyes. It just looked awful. And so I went off to Prof. Nishio and I was like, oh, I think this girl has got blepharokeratoconjunctivitis. And he came and took one look at her and said to the mother, did you use a new cream on her? And the mum was like, oh yeah, her allergies were playing up, so I put this cream on her. Next minute, she's all swollen like this. And again, obviously decades of his experience, he knew exactly that was the problem. But BKC typically would just involve the eyelid margins rather than being, all the skin around it. And the other thing apparently in her that gave it away was that when you put cream around the eyes, you kind of push it out to the sides, and the pattern of her redness looked like it came across the sides and down the edge. I was like, I couldn't tell that, but maybe one day we'll be able to. How long have the symptoms been there, and how do they change with time? So I always like this picture because it reminds me that if your biome around the eye, if your lids and lashes aren't any good, then you're not going to expect to have very clean windows. And actually for my exam, this was a little acronym that I made up at the time, and I found it very useful to think through logically what we're looking at when we examine the eye. And so external eye, does the eye actually blink? Have they got ectropion or entropion? Make sure they don't have any lid tumours or masses. What state are the lids in? What the eyelashes look like. Sometimes they can give you a hint, like I mentioned Demodex before, if you look at the base of the eyelashes. Any signs of inflammation or infection, and you need to treat that in order to restore the corneal health. Obviously you need to treat inflammation of the meibomian glands in order to have a good tear film again. And then what are you doing to protect the epithelium and promote healing? So if you see someone with multiple PEEs or an epithelial defect, what are we doing to protect the epithelium while we treat all the other problem? And then toxins and triggers, is there anything to avoid? And so this is both, are we using preservative eye drops that the patient's allergic to? Is it a glaucoma medication that's the problem? Or was it some sort of trigger like sunscreen or moisturizer that they're using, their old mascara that they've had for 3 years? Can you find something that you could get them to take out of their arsenal, make things better? So this hopefully will play nicely for us. So this is going to show a blink in real time, and I'm not going to ask any of you what you see. Then it's going to show it in slow time. It should be obvious what I'm trying to show. Same blink. And then when we slow it down, can you see it's just a partial blink? And so it's a bit unfair because this was just done on a slit lamp, so the person's probably trying to keep their eye open a little bit. But you see they're only just going across the pupil. And so when they do that, you might see the little PEE staining with fluorescein. If they've been really vigilant with eye drops, often you won't see the PEE because they're treating themselves well. But the partial blink might be part of what's contributing to the problem because they're not squeezing the meibomian glands, so they're getting stasis within the meibomian glands. They're not squeezing that fluid out onto the surface of the eye, so they're not getting the benefit of the oil on the surface. And so sometimes, particularly I find teenage boys, but in teenagers who are having a lot of screen time both at school and after school, just reminding them about the importance of blinking or getting their parents to remind them to give their eyes a good squeeze every now and then can make a bit of a difference. And so there are some conditions which are associated with incomplete or reduced frequency of blinking. So as we get older, people blink initially more frequently through middle age and then less frequently as you get older. Parkinson's patients are well known to blink less frequently as opposed to people with schizophrenia will blink more frequently. So there's a question about whether that's the dopaminergic circuit in your brain stimulating blinking. When we do certain behaviours, we blink more often, and when we do other activities, we blink less often. And we think that things that require greater visual attention may reduce the blink rate. So that's why someone who says, on work days my eyes get really tired and sore, it might be just that they're not blinking as often as they need to. And some of you might have heard the public health message 20-20-20. Every 20 minutes, look 20 minutes away for 20 seconds. And I always add into that, like, do some good blinking as well to try and refresh the tear surface. And then OCP may increase blinking rates. Post-LASIK may have a reduced blink rate. Is that because of damage to the corneal nerves? I haven't seen anything about whether smile has a lower influence on that. So there's a few different things, but if you notice, or you're trying to figure out why this patient doesn't seem to have bad blepharitis, but they seem kind of uncomfortable, maybe blinking's part of the problem. So I was trying to think how best to cover all the things that could affect your lids and lashes. And you might have heard a talk from Rob Weatherhead about this, and he might have mentioned the 7 Ages of Man. But this is something from Shakespeare. I'm not going to read you the whole thing, but it starts with infancy, a helpless baby. Basically, at first the infant's mewling and puking in the nurse's arms, and it gets better from there. The whining schoolboy with his satchel and shining morning face, creeping like a snail unwillingly to school. And then the teenager, the lover, sighing like furnace, with woeful ballad made to his mistress's eyebrow. I'm just going to read it. But yes, and so it goes on. But in infancy, children only blink about 2 times per minute to about 6 times per minute in preschool children. And the reason that children don't blink as often is they actually have a smaller surface area. As you grow, you get a wider palpable aperture. There's a much higher lipid content, and probably they have more complete blinks. So one of the theories is that your neural circuit is immature, so they kind of, like a lot of things that little kids do, they kind of have to do it completely. In Pittsburgh, I saw 2 children who'd been admitted for workup of seizures because they had funny eye movements, and it turned out they had dry eyes. But because they kind of roll their eyes in funny ways and squeeze them and then like kind of look up like this, and almost appearing to get stuck like that, which is why people thought they were having seizures. But actually the origin of their problem was their dry eye. So kids have really funny eye movements sometimes. Actually, one boy that I saw, he was really cute. He was about 6, and his mum was like, show them what you do with your eyes. And so he did this thing that he deliberately does. He's like, sometimes I just have to do this. And it was exactly the example of like just having a really good blink. So the question is whether in school-age children is dry eye more common than we thought. So they get meibomian gland disease, Stevens-Johnson syndrome, vitamin A deficiency are sort of main medical causes that we see of dry eye. But potentially as kids are using more and more screen time, they're having decreased rates of blinking, and potentially there's a role of high-fat foods like pizza, takeaways, fish and chips, where you don't have enough omega-3 and 6, or your ratio's not right. And so actually the oil that they produce isn't the kind of healthy, free-flowing kind of canola oil. It's more like toothpaste that they're making. Allergies obviously affect a lot of the population and probably affect children more than any other group in the population. So a lot of allergies people will grow out of or actually just learn how to manage as adults. So the question are, were these things always common and we just didn't diagnose them before, or are they truly becoming more problematic? So allergies is just an interesting thing because it's easy to lump everything together as allergic eye disease. So we've got seasonal and perennial allergic conjunctivitis, which is where you've got itching and chemosis, and the symptoms usually vary depending on allergen and exposure. And one of the problems we've got in Christchurch at the moment is it's really hard to access skin prick testing to actually work out what people's triggers are. So you're left kind of guessing a little bit. The seasonal allergies are usually the airborne pollens, grass seeds, things like that. Whereas perennial allergic conjunctivitis is often house dust mites, something that's in the child's home that they're allergic to, or pets is another big one. And then we sort of move through invernal keratoconjunctivitis. Is basically defined as occurring only in children, and if you grow up and you still have it, then we call it atopic keratoconjunctivitis. In some places, in order to have AKC, you have to have the atopic dermatitis around the eye. So again, it comes into a bit of a nuance of how do you define the disease. And VKC is kind of famous because it's the one that you get the large cobblestone papillae, you get mucus discharge, and you get the shield ulcer that needs to be managed as an emergency, or at least urgently. And one of the classic things is that VKC, the children are often so photophobic they won't open their eyes and let you examine them properly, because they've got these massive cobblestones and they're really uncomfortable. And then contact allergic reaction, again, often follows atopic dermatitis. So the child had dermatitis around the eyes, and then someone's put some cream on that they're then allergic to the cream, and that's causing further irritation. So then it's hard to pick out actually what the scenario is. So you can kind of lump them together. For our exams, we always have to know the definition difference between AKC and VKC, but I think clinically it's more important to think about them as like mild, moderate, and severe, or the active shield ulcer with a plaque. And I don't use a particular grading system for this. I'm just looking and getting a feel for their symptoms and their signs. For all of these conditions, I recommend cool compresses. Use any prescribed drops regularly. It's amazing how often a parent will be like, oh yeah, we got Patanol from the GP and we remember to use it on Mondays and Wednesdays. You're like, well, it's not going to work very well then. So encourage them to use it regularly. Some kids are better if they get the eye drop at school. Sometimes that's harder. So just depending on the parent's ability to put in the eye drops. Avoiding triggers. So some of the rules for outdoor play, I'd never really thought about this because I'm lucky enough I didn't have bad allergies. But kids who do get bad allergic eye disease, if they wear a hat and sunglasses that they take off when they come inside, they wash their hands, wash their face, you're trying to reduce the pollen burden. And so some kids might only need to do that for like 1 month of the year, but if you can prevent their allergies getting really bad before they're bad, then things will settle down with Patanol and oral antihistamines, and you're sort of reducing the pollen burden that their body can react to. No pets in the bed. It's amazing how often you see a kid with allergic eye disease and they sleep with their cat or their dog, or their cat and the dog sleeps on their bed earlier in the day. So I generally make that a rule, like no pets in your bedroom, and consider allergy testing if we can do it. Another hint that one mum gave me is that there's different homes are set up differently, and so like if you've got wooden floors, you need to be mopping more regularly to keep the dust down. If you've got carpet floors, then you need to vacuum regularly. But one tip she gave me is that if you crack the windows open in the morning and the evening when the pollen count is actually lower because of dew kind of helping settle the pollen, then you get some airflow through the house. Whereas if you always have the windows closed and you're allergic to dust mites from your house, then you don't get good airflow. So there's kind of all these little tricks and tips around. Sometimes I'll have a long discussion with the parents. Sometimes I'll just refer them on to some allergy websites or something. I don't have a good regime for Christchurch yet, but there's a lot out there, and it's a matter of trying to convince the parents that for the sake of their child's eye, your child has severe allergic eye disease. It would be really good if you could look up these things. It'll make a big difference. I guess in terms of oral antihistamines, I'm not sure whether that's something you guys prescribe or just refer to the GP. Make sure they're taking it regularly, because even though it doesn't always feel like it's doing much, if you've got that oral antihistamine on board, then what we do adds on top of that. So that's really helpful. And then mast cell stabilizers, there's now recommendations that you start that about 4 weeks prior to allergy season. I haven't typically done that because I thought, you'd wait until you became symptomatic. But some kids really know when their allergies, well, I presume adults as well, know when their allergies are going to start up. So it's worth getting them to start it a little bit earlier. Do not rub your eyes. So the more you rub your eyes, the more that you're going to break open the mast cells, the more itchy your eyes are going to become. So I try and get parents to give their child a cool compress if they see the kids rubbing their eyes. And that just acts as a barrier, so then they actually physically won't get in and rub their eyes. But that's when you're going to have your problems of causing keratoconus, corneal abrasions, things like that. But it's also a sign to me that this kid's allergies are not well enough controlled. If they've still got itchy eyes, we should be trying to do something more. And then expectation management. I always try and tell parents, I don't know yet whether your child has seasonal allergies or whether this is just going to be throughout the year. If we can identify a trigger, that helps. You might need to go through this intense regime 2 or 3 months of the year, and then things will be settled for the rest of the year. This might go on until they're 18, but we need to stay on top of it because we don't want corneal scars that are going to damage the vision for the rest of their lives. So classic vernal, where we've got the large papillae on the upper tarsus and the hornus trantis dots and the limbitis. And it's interesting because I feel like over time I've been seeing more and more that it's one or other rather than the mixed type. You can get mixed and have both presentations, but sometimes you might just see the child's got mildly inflamed conjunctiva, no real limbitis, and then you flip the lid and you find these giant, big papillae there. So it's, and again, like I'm amazed how many kids will let you flip their lids, so don't be scared to start doing that. Some kids do it in the school playground, so if they can do it, so can we. So again, just in terms of managing pediatric allergic eye disease, basically all the simple things that I've talked about, we should be trying to do that for all children. And then if they're getting a moderate reaction, then some steroid pulse therapy is appropriate. Try and get them on. So I try and start with Predfort or Maxidex 4 times a day and review them in a couple of weeks to see if that's been enough, and then wean it down. Again, depending on what the trigger is, I think some kids you can wean it down quite quickly, like every fortnight we're going down 4, 3, 2, 1. Other kids, presumably if they're allergic to something that they're still being exposed to, it might be a month at each stage and then alternate days, and it takes way longer to get them off. If they've got severe eye disease, this is it doesn't project very well, but an old healed shield ulcer. So that child's proven that they have an immune system that's capable of being very destructive of their cornea. So if they're building up a response, then I'd get in there early. I'd give them a pulse of steroids to get things under control. And then it's been great. So we can get cyclosporin compounded. So I guess that's something we're doing. Getting cyclosporin to reduce the amount of steroid that they need. The downside to cyclosporin is that it stings. So if we want to use it, some people use it as low as 0.05%, but then it's probably only as effective as Patanol. And so we want to be using it at 1 or 2%, which can be a bit stingy. But depending on how severe the child's eye disease is, that stinging for a few seconds might be well worth it. And then follow up in a couple of weeks to see if they're getting better. And if they're not, and they've proven that they could mount this terrible response, then you'd be thinking about whether you're going to take them for a GA, supratarsal steroid injection. And the other thing that I learnt, I think it's on, I might come over it again, but while I was in the States, it was interesting because we were putting children on topical tacrolimus. Oh yeah, I've got some good photos, I'll show you in a minute. The tacrolimus, which we can actually get here on special authority, and it's approved for periocular dermatitis. So it's actually very easy for me to tick the box and order topical tacrolimus. You're using it for treating the lids, the skin lids. It's not going in the eye, but enough of it acts around the eyelids that it can make quite a significant difference to these kids' eyes. So I think this is, in terms of trying to define atopic keratoconjunctivitis, there's a range of symptoms that you see in the lids and the lashes, really. So all of the children with severe AKC suffered from eczema and conjunctivitis or keratitis before the age of 16. You can have follicles and keratitis, thick and dry skin in greater than 83% of them. And this was a study done to review, trying to define the difference between AKC and VKC. So the thick and dry skin, I think most of you will know what I'm talking about, and people who have chronic eczema. Sometimes that can be as bad as causing like a little bit of ectropion, but often it's just, even wearing a mask, you can see how bad their facial eczema has been. Denny Morgan folds are the little creases that children get in their lower eyelid where they're not really supposed to have folds, but their skin's so thickened that they've got like little extra wrinkles. And if you've got a single fold, it's less severe as if you've got a double fold. So it's like a little extra for experts. But again, that's something that would point you to saying this is likely to be AKC rather than VKC. This could be a lifelong problem for this patient. They're less likely to grow out of it. And then blepharitis, I find it really interesting that you get all this atopy and all this swelling and inflammation of your eyelids, you're more likely to have blepharitis. And presumably that's because of the damage that it's doing to the meibomian glands themselves, which are becoming blocked. So yeah, so these are the photos from this paper which looked at tacrolimus. So it's just using the standard cream that we can get here, and they're putting it on the lid skin and nothing in the eye. And this was the response of the vernal keratoconjunctivitis. So I was kind of amazed by this. And one thing that's kind of amazing is that when we're in the States, we'd have to fight with the insurance company to get tacrolimus ointment funded, and if you didn't have funding it would be hundreds of dollars, whereas here I can go online to do a special authority, tick the box that says that they've got atopic dermatitis, here's your cream. It's kind of not the usual way around. You kind of think you'd have more options in the States. So I'll definitely be putting a few more kids and probably young adults on this because it's a really nice option. Another thing to be aware of, that atopic disease and bilateral HSV, there's mounting evidence that people who have atopy have an unusual cell-mediated response and probably aren't as well protected against HSV. So you might see someone who's got chronic atopic disease, they're used to having sore red eyes, and then they come in and it potentially looks like they've even got bilateral dendritic ulcers, and they could well have that. So that's something to keep on your mind, because if you try and treat that with steroids, you're obviously only going to make things worse. So just a heads up about that, I suppose. They're more likely to have severe HSV infection and maybe less likely to respond to topical treatment. So this paper actually went as far as to say if someone's got atopic disease and HSV, we should just be putting them on oral acyclovir for children, valacyclovir for adults, and sort of skipping the 5 times a day acyclovir. This little girl, this is just a reminder, this is just primary herpes simplex. So I'm not sure if there's quite a lot of light in here, but she's just got the vesicles all around her cheek, but actually her eye is white. The vesicles go right up to her lash line, but vision was good. So the epiphora and the mucus discharge is coming because of the inflammation of the skin, not originating within the eye. Yeah, it's not a great picture. So this child now, we know that she's had primary HSV, so she's more likely to present later with corneal HSV. And then just a reminder that although allergies are really common and up to 20% of the population is going to have some allergic eye disease, for some people it can have very severe ocular outcomes. So at the public hospital in particular, I get to see the severe outcomes of people who've had poorly managed atopic disease. I saw a man present with bilateral corneal perforations, white eyes, presumably his perforations had happened at some point in the past. We were just talking about the keratoconics who turn up with 660 vision before they choose to see anyone. Patients with posterior subcapsular cataracts from atopy, presumably some inflammatory drive, and or they've had steroids in the past. But again, for some reason, whatever their milieu is, they present late. So I tend to try and treat atopic disease quite seriously, try and diagnose what it is, why they're getting it, and then manage it. And I try and stress that to the patients. I think sometimes when we say, oh, you've got allergic eye disease, it's almost like, oh, there's nothing really wrong, it's just allergies. But I'll say to them, no, like we need to make sure that we're managing this. If things get worse, come back and see me. And then the other thing we're becoming more and more aware of is meibomian gland disease. And if you've got chronically inflamed lids and you're going to wipe out all your meibomian glands by the time you're 45, then you're going to have dry eyes later. So everything we can do to preserve the meibomian glands and prevent dry eye later is probably a good thing. And just the quality of life, like we've all seen the patients who are miserable with their allergies. They don't go outside, they can't play at school, they're home from school because of their allergic eye disease. So also when you actually drill into what families are doing to manage their children's eye disease, it can be quite a lot. So I'm not going to get too much into things that you probably have a million talks on every year. Meibomian gland disease, just to touch on that, I tend to vary my treatment regime based on how severe it is. Some patients are quite symptomatic, even if their meibomian gland disease doesn't look that bad, and those ones I usually do just give them advice about what's going on, hot compresses, massages, lifestyle advice. They can't play at school, they're home from school because of their allergic eye disease. So also when you actually drill into what families are doing to manage their children's eye disease, it can be quite a lot. So I'm not going to get too much into things that you probably have a million talks on every year. Meibomian gland disease, just to touch on that, I tend to vary my treatment regime based on how severe it is. Some patients are quite symptomatic, even if their meibomian gland disease doesn't look that bad, and those ones I usually do just give them advice about what's going on, hot compresses, massages, lifestyle advice. If it's moderate, I'll add in some doxycycline orally for 3 months, potentially adding an FML in claw fast and then tapering that down. I think sometimes when patients come in and they've got a lot of symptomatic meibomian gland disease, and now I'm asking them to do hot compresses and lid massage twice a day for potentially 2 months, that's quite a lot. And then if I can give them some FML, they'll feel a lot more comfortable quickly. So then it feels like their treatment, which is the massage, is actually doing something. They're more likely to stick with it. That's what I feel like anyway. And then also there's the option between doxycycline and azithromycin. And I think it was Malcolm McKellar that told me that azithromycin is quite good if they've got really foamy blepharitis, where it looks really inflamed and you want to hit it hard, because you just give them the big dose for 3 days. But part of what I like about doxycycline is you're saying to somebody, this is a chronic condition. I'm going to put you on this low dose of antibiotic for 3 months. You're going to massage your eyelids for 2 months. We're going to manage this. It might come back. This is a long-term problem. It's not a quick fix. And so I feel like doxycycline kind of adds weight to that side of things. And then obviously if it's really severe, I've seen a few younger people, like in their 20s, and couple of kids that we've taken to theatre, put them to sleep and really given them a good squeeze out of their glands, because they're all so blocked up that they're never going to win with massage. But I don't know if many of you guys are doing that at the slit lamp, but often the patients love it because they feel so much better straight away. Demodex, have you guys seen much of this here? Yeah, okay, good, because I've learned about it in the States, but I haven't seen anyone at the public hospital with it. And I'm not sure if it's just that I was missing it as a registrar or if we didn't have it that much here. But my first few cases of Demodex that I did pick up, it was just because we'd done photos for their anterior segment disease. I was like, oh, this person's got blepharitis and Demodex, and now they're getting corneal neovascularization from their BKC. But it wasn't until I looked at the photos and could really see the cuffing to say, oh yeah, this is Demodex. So I managed Demodex with sort of like a 1/4 teaspoon of tea tree oil shampoo. So you can actually just get the shampoo which has got some foaming rather than the straight oil. Put that in 1/2 cup of warm water. So it's really diluted. You don't need much of the tea tree oil at all. And in fact, if you use higher concentrations, often it can dry out the eyelids. And again, that can be a chronic condition that takes a lot of washing of the eyelashes to get rid of. Screen time, I think we all know we're spending more time on desktop and laptop computers. So tips, again, for patients with dry eyes or really any eye irritation, is you want the screen, if your screen is higher up in your visual field, then your eyes are open wider. So you actually want your computer to be below your visual axis, so your eyelids are partially closed, and that will help prevent dry eye. Staring at a computer can cut your blink rate by half, so I think I've already talked about that, to just remind people to blink. And it's been proven, myopia is a whole talk for another day. I can talk to you all about that one day. But basically having the screen further away and bigger text is better for your eyes generally. And then if it doesn't seem to fit in one of our standard categories, just remember that there's some other things that can masquerade. So SLK, ask about whether they're hyperthyroid. Medication toxicity or medicamentosa, mucus fishing syndrome. Do you guys know all about that? Yeah, it always makes for some good photos. Conjunctivochalasis. And again, it's a bit tricky at the moment because trying to see patients at the public hospital for conjunctivochalasis is pretty hard to get them in, but we could see them here. And then thygosins is really interesting because they'll look like they've got some little PE and white spots, but probably pretty quiet eyes. You give them steroids, the PE will go away, SPK will go away, and then it comes back as soon as you stop the steroid. And those kids are usually like photophobic, maybe slightly watery eye, but their conj is still white, so it's kind of confusing as to what's going on. So that was just a few things I wanted to flag. And I think that's all from me. So do you guys have any questions? Or you can just come and ask me later. Yes.
Stephanie in the white top over there and myself, we have a lot of patients coming with just really grumbly, inflamed lids, like kind of grey to papillae, like it's not GPC.
Yeah.
The tear film is usually quite abundant and fine, but they're just kind of really aggravated. It's not itchy.
Yeah.
And we've just been dishing out FML
It's good stuff.
Over and over.
Yeah,
And we've
yeah.
kind of, today we were having a conversation like, are we going to be pulled up for it? Because there's so much of it presenting to us.
Yeah. I mean, my short answer is I think FML is very safe. So I've yet to see anyone with ocular hypertension from FML. Ken Nischel published a big study of I can't remember, I'm not going to try and guess the number, but it was, several hundred children, none of whom had a steroid-related pressure rise from FML. I think one of the tricks for using FML is that for those people who grumble along is if you go 4 times a day and you get a good response, do that for a month, and then 3 times a day for a month, twice a day for a month, once a day for a month, alternate days for a month, and then you might get it down to twice a week, and they may need that to maintain things, but if you're on FML twice a week, you're not going to run into trouble, within the realms of medicine. But
do you have any idea of what does it? And these people sometimes
Yeah.
are 10 years,
yeah,
know.
I mean, my guess is it's probably the milieu of what oils are they having in their diet? Should they be? Another option is to supplement with a flaxseed oil, see if that helps, just to improve the quality of the oil that they're making. It might be mild allergies that we can't pick up, and it's a house dust mite allergy or something that. I mean, a good question for those people is, if they lived somewhere else, did this just start when you moved to Christchurch, or when you were living in Wellington, was this not a problem? And then I guess the other thing is just watching their meibomian glands. Are they actually clogging up meibomian glands and getting slow atrophy of the glands? But yeah, if they've got mild papillae, that does suggest that there's an element of allergic conjunctivitis there. And if they respond really well to FML, that also suggests that it's their immune system that's showing it. But yeah, I think, as long as you're watching them, then using FML to control the inflammation is reasonable.
How frequently would you get them back?
Yeah, so if you were doing 4 times a day, so at the moment what I like to do is 4 times a day for a week, 3 times a day for 2 weeks, twice a day for 2 weeks, once a day for 2 weeks, and see them back at the end of that course.
Okay.
If you've tried that and as they wean down, that it appears like they need a longer, slower taper, then you could stretch that out and still just see them towards the end of that course. Or get them to call you if they drop down from every day to every other day and they don't think that that's maintaining things, and they say, oh no, I really need it every day, then I'd probably just stick with it for a month or 6 weeks before trying again to go down. But yeah, it certainly works pretty well on kids if we taper them down slowly, so it's almost like the immune system doesn't notice that you're withdrawing the FML. Yeah. But also, I think for the patients that I see for the first time and I'm putting them on FML, I will tend to do that sort of 4, 3, 2, 1 over 6 to 8 weeks and see them back at 8 weeks to see where we're at, because they might not need it anymore.
How long do you find before, it's quite a long course, I've been seeing everyone after 2 or 3 weeks, and now I'm maybe that's just too quick. Do you find it really takes quite a while? At what point can you expect them to feel a little bit of comfort?
Better. Well, I mean, the FML tends to work pretty quickly, so
Right.
seeing them back at 2 to 3 weeks is not a problem. I mean, then you know that it's working, that they're more comfortable, and then you can say carry on, and I'll see you, when you're off them. They're not going to have, any complications from the FML in that time. It probably is partly what you expect and what they expect. So if you say, hey, look, try this, I'll see you back in a couple of weeks to see if it's working. Some patients will want that because they don't want to be sent away for 2 months. And other patients, you get the feel that, if this is working, they don't want to come and see me in 2 weeks.
Right.
So I think, judge a little bit on that. Because, basically, in the realms of this setting, FML is very safe. So seeing them in a couple of months should be fine.
I know it's MG, sorry.
Yeah.
You also use Chlorfast.
Yeah.
That's more for MGD, that you're controlling inflammation.
Yeah, rather than allergy. So particularly if the meibomian glands look really inflamed, I don't know if it's just, I feel like having a bit of antibiotics as well as the steroids helps. You're settling down the inflammation, but you're also treating any staph infection that they've got, particularly if they're prone to styes. They've shown that they've got a high staph burden, that when you put them on the steroid and you're relatively suppressing their immune system, they may not need the core fast, but I always feel like it's good to cover your bases there.
You try that ahead of IPL, or
Yeah, so I mean, maybe you guys could tell me. I don't have much experience with IPL, so yeah. I mean, at what point would you guys do IPL? I don't know.
so we tend to do IPL where we've definitely got a confirmed inefficiency in the oil production.
Right. Yeah.
And typically there's no evidence sort of blepharitis or anything else that might be preventing that from happening.
Yep.
So pretty
Yep.
much it's an oil layer deficiency. So non-invasive
That's
tear
it.
breakup time is low.
Yeah.
And yeah, and we tend to go straight.
Straight to that
To
rather
it.
than treating. Yeah, that
Yeah.
makes sense.
Yeah.
Yeah, because there's less. You're not treating so much inflammation.
Mm.
Yeah, that makes sense. Yeah.
But I do recall ophthalmologists quite frequently using like Maxvex or like some sort of antibiotic steroid combination.
Yeah, so you can use Maxitrol as well. Yeah, and yeah, some people would do that. I haven't tended to because I like to use the FML separately from the Chlorfast so that I can kind of taper them separately if needed. Some people argue that just confuses the patient and you should just use one drop. Yeah, exactly. And if a patient came to me and they had been using Maxitrol successfully prescribed by somebody else, I'd probably just stick with that and I wouldn't feel the need to change them to my regime because it's better. There's not good evidence for that. Yeah. Cool. So anyway, we can carry on talking now. Cool, thanks all for coming.
Thank you.